Join me in welcoming Dr. Jenna Hightower. Welcome.
Hi, everyone. Thank you for joining. Everybody take a minute and just stand up for a minute. Stretch. Okay. Stand up. Stand up. Or standing. Who in the room is a healthcare practitioner? Practitioners in the room? Right? Industry partners in the room? All right, great. You guys can sit down. Now, if only it was that simple for our patients to just stand up. So, as said, I'm Dr. Jenna Hightower. I am a critical care physical therapist, or physio, as also referred to, and I'm board certified in cardiovascular and pulmonary physical therapy. I specialize my career in mobilizing patients with mechanical circulatory support, pre- and post-transplant populations at places like Mayo Clinic in the United States and Piedmont Atlanta Hospital. I serve as the Director of Clinical Strategy for VitalGo Systems. VitalGo is the inventor of the Total Lift Bed, which is the first in-bed verticalization product on the market. And we are a global company that has been adopted in many hospitals around the globe, such as Mayo Clinic, Johns Hopkins, Stanford, Hartford, and other legacy institutions. So I'm going to talk about a range of things today, so just kind of buckle up and hang in there with me. But first and foremost, what we do in healthcare is we put our patients in the hospital and we keep them in bed to save their lives, or what we believe is saving their lives, but we are sending them home in a shell of who they were when they entered the hospital. So there's many complications associated with bed rest, such as muscular deconditioning, other complications like pressure injuries, increased infection risk, which leads to other complications such as respiratory decompensation, which can cause prolonged ventilator support, prolonged hospitalizations, prolonged ICU stays, which in turn cost our healthcare systems a lot of money. But what I want you to really think about, what I really want to paint the picture here for, is what we're doing to these patients. So most people go into medicine to save lives, but what is saving a life if they have no quality of life when they leave the hospital? And they have this for many months and often years after they leave the hospital. Many people that are admitted to intensive care don't return to work, especially don't return to work for at least 1 year post-hospitalization, have long-term cognitive deficits, and there's a lot of research on this, long-term physical deficits, and require prolonged care for a long time getting out of the hospital. So what if we had something that could change that? Well, we already know. Early mobility, there's all kinds of research on it, yet despite all of the research that is out there, it's still not being done. It's still not well defined in the research. What is even early mobility? And why? Why is early mobility important? Why is it good for our patients? Well, what I would like to talk about is both our product and why it's important. And what if we could do this at the push of a button? So this is a very quick video sped up for the time purposes here. But as you can see, despite how sick the patient is or what they have attached to them, and this is a fraction of what most patients look like in the ICU, if we could do it at the click of a button, slow, titratable, in a controlled environment where it is safe. But it's more than just mobility. Mobility it affects every single body system. So there are many more physiological benefits to being upright and mobile than just moving your muscles. So this is a screen of electrical impedance tomography, which is a new technology that is coming forward to help patients wean from ventilators and safely titrate their ventilators. However, this is actually my data, obviously a very healthy person. And as you can see here, see if my pointer will work, this is my end expiratory lung volume, so just the ability of air that I'm able to hold in my lungs with a simple position change of verticalization. And you can see how much lung volumes alone increase just with being upright. So many benefits to respiratory system for being upright. I always tell my patients, I still see patients in patient care. I worked 2 weekends ago. And I always tell them our bodies are not made to be flat. And this is a clear picture of that. So even from supine to sitting, you can see the difference in the lung volumes. This is CT scan out of an article. And then from sitting to standing, even more volumes. So what happens is in upright, our abdominal contents come off our diaphragm, and we're able to expand more. Also, when we're laying flat on our backs, our heart is compressing our left lower lobe. So when we're upright, it brings that off the lower lobe, even more expansion. We have improved ventilation perfusion matching, or VQ matching, and improved PF ratios, or improved oxygenation through those things. So PF ratios is comparing how much oxygen we're giving the patient compared to what's showing up in their bloodstream. So how much is actually getting through, and that's how we track how our patients are improving, especially on ventilators and ECMO. And this also can help in pulmonary hygiene, both in fluid redistribution for patients that have very sick lungs, and then also helping their cough effectiveness, cough management, and getting stuff out of their lungs. And then, of course, if you're more upright, you have reduced aspiration risk, reduced ventilator-associated pneumonia risk. And then some interesting data actually came out in 2023 that this hospital in China just passively tilted sedated patients, actually, from supine to upright on a tilt table for just 30 minutes a day. And those patients showed decreased diaphragm atrophy with patients on ventilators. So a lot of people know that once you put a patient on a ventilator, your diaphragm effectiveness decreases very rapidly because the ventilator is doing the work for you. Use it or lose it. And this data showed that the very simple change of position reduced the amount of atrophy that those patients had, which is really interesting. Cardiovascular benefits. So again, another use it or lose it scenario. So if our body doesn't change positions very often, then we lose our ability to regulate heart rate and blood pressure. So we want to stimulate our baroreceptors in our blood and prevent and decrease vasoaplegia. Vasoaplegia, I see it all the time in patients that I see in the ICU. If they're supine for a long time, if they are septic or have other cardiovascular disorders, they often drop their blood pressure when you stand them up. So this is a way that you can retrain that, but also help prevent that dysfunction. Of course, using muscles helps decrease risk of blood clots, which is another risk of being in bed for a long time, and improving our ability for cardiac endurance and ability to tolerate upright. Musculoskeletal, this is an obvious given. So we have to use our muscles to lose them, or we lose our muscles if we don't use them. So gravitational loading, axial loading, it also stimulates bone remodeling. So osteoporosis is actually a problem that occurs in patients in the ICU as well. That's not talked about. Neurological benefits. I think this is kind of the most under-recognized portion of position changing and mobility. Oftentimes, especially patients with neurological impairment, if you leave them still and don't stimulate them, their outcomes are much worse. But if you sit them up and change positions, it helps stimulate them. It helps stimulate things in your brain like proprioceptive input and neuromuscular or reactive forces, and improving alertness. And this all helps to serve as a non-pharmacologic aid for delirium. ICU delirium is a very prevalent problem in the ICU, especially during COVID, because not only did we have ICU delirium, but we had isolation delirium. And then gastrointestinal and urinary. Gravity helped everything, including our bowels and our bladder, to help empty in a natural body position, prevent reflux, and to help prevent infection. And then skin. So what's the best way to prevent a pressure injury? Is to get off of it, to stand up. And again, another simple intervention that we do not use enough in healthcare, and instead create problems in healthcare. So verticalization can be a means to offload bony promises and serve, in addition, intervention to traditional Q2 turns. but also we're not pulling and tugging these patients, creating shearing injuries, especially on our more frail patients. So what if we had verticalization? Verticalization has been around for a long time. Tilt tables have been around for a long time, but often it takes a lot of staff, a lot of resources, and can be potentially very dangerous to patients to go back and forth to a tilt table. So now we have this technology where we can do this not only easily, but more often throughout the day in something where it already has all of the features of an ICU bed. So we have our power drive technology that is the OmniWheel technology, so very easy to drive and maneuver. It's one big wheel with a bunch of little wheels on it, so it's a single axis point, very easy to turn. I like to joke with my nurses that I can drive it with one hand and a coffee in the other, which is not the most case with a lot of ICU beds on the market. And then, of course, necessary emergency procedures for patients that may decompensate during their time, so both head of bed manual lowering and the tilt manual lowering, so patients can never get stuck in upright if there's some sort of electronic failure. New line management systems is another convenience factor in the ICU, especially for the very high acuity patient populations. They're also very adjustable, so we can make them longer or shorter to help give you the extra hands that you don't have in the room. I always say I wish I had a third arm in an ICU room. It would be very convenient. This can act as that. It's completely fluoro or CRM compatible and X-ray compatible. Integrated therapeutic mattress, so of course patients that aren't getting up and moving around very often, you want a therapeutic surface under them, alternating pressure, low air loss, microclimate control. And then of course full chair position. And what unique about our chair position and that I love, especially as a physio, is we have a movable footboard, so I can pull that footboard into my patient so that feet can be supported. They have nice supported posture like they're actually in a chair and not all slumpy in the hospital bed that we see classically going on in sacral sitting, creating those pressure injuries. And then I also can use it to reposition my patient. As a physio, I use it very often to create resistance training. So we have a patented biofeedback display that lets us know exactly how much weight the patient is pushing through the footboard. It can tell me exactly what percentage of body weight they're able to tolerate standing. So I could say, my patient tolerated 50% weight bearing at 45 degrees for 30 minutes on such and such support, and then tomorrow we want to try to progress from that. So making sure that we're tracking everything that we're doing, justifying what we're doing, and justifying paying for such technology. So why is it important? Why is it such a big deal that we can have an ICU bed that does this? Because there are so many patient populations that don't get mobilized or don't have opportunity to be mobilized either because of their device, their complications, how much they weigh. And so the idea behind this technology is not only that we're mobilizing our patients, we're getting them upright, we're getting those respiratory benefits, we're helping them wean from the support, but we're doing it earlier and more often so that we're getting the outcomes that we want. So first and foremost, respiratory therapy or respiratory failure. So we have talked about all the benefits of this already. I don't need to repeat them. But patients that are on high ventilator requirements, prolonged ventilator requirements, non-invasive ventilation, so trying to prevent intubation is very important. I've actually prevented intubation on a lot of my patients. This is actually my patient here. Being able to help them wean from support, come down on the peak pressure, so coming down on potential injury in their lungs from high ventilator requirements. Verticalization actually has very similar benefits for proning. There's some new data out of France to show that, and we're working on some larger studies with Mayo Clinic to put some data behind this and hopefully change the standard of care for ARDS patients, patients that have a very high mortality rate and a very high complication rate. Extracorporeal membrane oxygenation, so this is my passion, my bread and butter. So these patients are very challenging. They're very sick. They are the sickest patients that exist in our hospital systems. They have a lot of support attached to them, so often they have CRRT, a ventilator, 12 IVs, and all kinds of other support, and they are very dangerous to mobilize. So those who aren't familiar with ECMO, It pulls the blood out of your body, oxygenates it, and puts it back in. Now, these cannulas are about the size of a water hose. So you can imagine if one of those becomes dislodged when the patient's moving around, it could be fatal. It could be very dangerous. But high risk, but also very high reward. And the total lift bed offers an opportunity for these patients to be mobile in a very safe and controlled environment. Also, they don't tolerate mobility very easily. So you go to sit them up and they may quickly decompensate. And this allows us to slowly titrate them into upright. And they're in the room with the physicians, with the respiratory therapists, with the nurses at times, so that they're titrating their support to figure out what we need to be able to tolerate mobility. So say they're only 50% FTO2 at rest, but they need 100% for activity. But that's okay, because if they can move and they can stay strong, they're going to do better. So figuring out what support they need to be able to do the best. Also, for those facilities that what I would call a well-oiled machine at mobilizing these patients, they do it well. Well, this is still important. So I'm very lucky to work at an institution that mobilizes all of their ECMO patients, no matter what the cannulation style is. But that's still only happening for once a day, and it takes 6 people to do it, depending on what other things the patient has attached to them. And so think about when you're sick at home, how often are you getting up to go to the bathroom or grab a drink of water or to the kitchen? It's often. So if we're laying in bed and only getting up for one short period of time, it's not enough. And that's what we do to our hospital. We rely on the physios to get them up out of bed. Well, one time a day is not enough. So allowing them to mobilize multiple times a day with just one clinician is very beneficial to these patients. So intra-aortic balloon pumps and Impellas. So this patient population is traditionally on very strict bed rest. So those who are not familiar with intra-aortic balloon pumps, it's a pump that sits in your aorta. It inflates during diastole, or the relaxation phase of your heart, and then deflates during systole. So it can help increase blood flow to your heart tissues, but also serve as a little bit of cardiac output. So often these patients, they can use this device as a bridge to heart transplant as well. Same for the Impella. The Impella is a percutaneous temporary ventricular assist device. And same thing, if it's inserted in the groin, patients cannot flex their hip past 30 degrees. If that device moves, it could damage the patient's heart, and in worst cases, damage their vasculature and bleed out, which is very dangerous. However, there are many states in the U.S. that have been ambulating these patients with the total lift bed because it allows them to not break that hip precaution and move around safely. And obviously, not every patient is a candidate for ambulation, but every patient can at least verticalize in the bed, which is very, very important. And again, it's getting upright and weight bearing more than just one time a day. The physiotherapist is actually who trained me, Dr. Stephen Ramsey. He has a whole protocol that he published beautifully. The DOI was there. If you contact me, I also can send it to you. But again, if you're comparing patients that are getting up and walking around to those that are laying flat in bed, it's night and day. There is no comparison. And as you can see, I'm very passionate about this because I've seen this many, many times. Critical illness myopathies. So this is a given. Patients that are very weak, they've indicated they've been sedated for some time, they've become very weak. This is actually how this product kind of got started. These patients are difficult to mobilize. They often don't tolerate mobility for very long. So it's a way to accelerate their rehab process and be able to slowly ease them into the activity that can tolerate and free up the hands of the clinician and keep the clinicians from injuring themselves. It can be very dangerous. This is a passionate piece of my career as well. I treat patients with end-organ failure, and often they end up very weak. But if we're able to intervene on the front end before they have transplant, we can drastically impact their outcomes. So especially important in the populations pre and post-transplant. Large and severe burns is another key population for this technology. Verticalization is actually part of the standard of care already for burns, especially in the U.S. However, it's often an afterthought because these patients often require going back and forth to the OR many times. Mobility can be very challenging with these patients because they have very strict wound healing protocols. They have large volume shifts. Their body is in chronic inflammation from large and severe burns. So mobility is important, but it also has to be done very strategically and carefully. And so this technology offers us a way to do this, again, more often and frequently. And that's easier for the staff, more time efficient for the staff. With this technology, I could see 3 or 4 patients of this caliber in a morning instead of just 2 or 1 because of all of the organization it takes to go on and off devices. So very, very important population here. And then neuropopulation. So again, dense strokes, brain injuries, spinal cord injuries, neurological surgeries or brain tumors, spinal surgeries, and then your neuroprogressive disorders. So neuroprogressive disorders often end up very weak and then they slowly get better. And making sure that we are intervening in any way we can very early on is very important for neurological remodeling. And often these patients are very hard to rehab, very costly to rehab, very prolonged. And if we can get in early and more often, very on, we can drastically impact their outcomes. And then complex surgeries. So this is something that's been a hot topic today. Complex surgeries are difficult. And oftentimes we don't see on the back end, especially if you're in the OR or in the ICU, how long it takes those patients to recover. It's months. Oftentimes, if it's a complicated surgery or if there's multiple organs or multiple limbs involved. And so being able to tolerate weight bearing on a single limb is very important. Or pain, abdominal surgeries are very, very painful. I myself had a C-section last year, and I tell everyone it gave me a whole new perspective for my patients because moving after those is just impossible. And so having technology to help us do that is important. And then, of course, bariatrics. So bariatric patients are our most difficult to mobilize because they're not like your 40-kilo grandmother that you can just pick up and put in the chair. They require mechanical assistance. And often, if you leave them in bed and they lose their ability to tolerate their own weight, they never walk again. So being able to keep the ability to bear their own weight and also helping them be more successful in weaning off a ventilator, they often require a lot more pressure to inflate and keep their lungs open. This actually was my patient during residency, and we extubated him in the standing position, so weaned him from the ventilator in the standing position to help him be successful, and we left him like this for a few hours after extubation to make sure that he was continuing to get oxygen and inflate his lungs. So very, very important in this population. Of course, there's a couple added benefits to the total lift bed outside of what I've talked to today. So a little bit on this of caregiver injury prevention. So being able to position and maneuver your patient at the push of a button is important. But what I love to add, I think sometimes safe patient handling gets a bad rap with physios because they think that it's passive. It doesn't have to be passive, it can be active. And this is specifically a technology that you can maximize using technology and making sure that your muscle or your patient is using their muscles actively as well. So very, very crucial in that aspect, and making sure that the patient is able to move themselves in a way that is very safe. And also preventing your caregiver burnout fatigue. And then through all of this that we've talked about today, we're saving the hospital money. So reducing risk of readmissions, complications, ICU liquid stay, ventilator stay, helping mortality rates, readmission rates, very important. Workman's compensation, the hospital being liable for their caregivers getting injured, and then of course improving staff efficiency. So what I talked about is not having to go back and forth to all of these devices. It saves a lot of time, which is something I appreciate because it frees up my hands to see more patients. And then of course, last but I think most important is patient satisfaction. That's why we're all here. We're here to improve the lives of our patients, improve their quality of life. Like I said, what's the point of saving lives if they have no quality of life when they get out of the hospital? So I've done this for a long time, and I have put many patients of my own on this bed before I ended up working for this company. And this is why I ended up working for the company, is because I truly believe in it. It's something I'm extremely passionate about because it is a lifesaver and a life changer. And I hope that you all can see that through this presentation today. So thank you for having me. Please come by, see the vet in person. It speaks for itself.